I'm Dr. Michael Latola.
And I'm Megan Strong.
In today's case of the week, a dentist sends in an impression the likes of which I've never seen.
And bad dog, what you gonna chew? Well, it turns out there's one dog who took a bite out of crime and he turned to strangers for help.
And there's a dental laboratory in Springfield, Ohio that has bargain basement prices, and that's because it's actually a bargain basement. That and more on today's Chairside Live. Hey now, hello, and welcome to episode 77 of Chairside Live. Megan, how are you?
I'm doing well, but today the high here in Newport Beach is supposed to be around 80-something, and it's November, and I'm over it. And I know people probably, dentists in Michigan, are screaming at me right now because it's probably negative.
It snowed there yesterday, as a matter of fact. While I was at the gym today, I heard the TV on in the background, and Michigan got snow as well as some other places.
I absolutely believe it. And so while people may be jealous of the weather here, I am officially over it, and I wish it was cold.
But you don't want snow, because your commute today would have been a lot worse if there would have been a foot of snow. You still wouldn't be here.
I was telling one of my coworkers that I want snow, but I want the kind that doesn't interfere with your life, the kind where you don't have to, shovel it out of your driveway. And she then promptly said, "So you're talking about Disneyland snow?"
You're talking about the kind that was on the Christmas trees when I was growing up, that flock stuff that they used to blow out of that big thing. Because every time I say that to people, and I say it a lot, and when you say it to people who grew up in the snow, they say, "You've never lived in the snow, have you?" And I said, "No, I haven't."
What
And
you're
they go,
about.
You're a little naive, but you can continue to think those beautiful thoughts. I just want it on Christmas Day.
Yes,
I hate looking around in Southern California when people have shorts on. I want to go around with a big tank of liquid nitrogen, a couple hundred degrees below zero, and just give them frostbite.
I advise against that.
Well, it's probably not a great idea, but we've got a great show for you today and an interesting case of the week. We have a case of the week where it's the first time I've actually seen a dentist attempt this in my 25 years of practice, and I'm not sure. Maybe you guys have tried this before, and you can let me know if you have. Certainly, it's not something I'm familiar with, but I guess it's kind of a modified copper band technique, but not really. But I'll let you take a look at it. It's hard to explain without seeing it. So let's go to that now. I was sauntering through the Crown and Bridge department the other day, and I saw a case that had a bunch of stickers on it and question marks, and I thought, oh, this should be good. So I picked up the impression and took a look at it, and of course it's a double arch impression in a plastic double arch tray, and it's for a single unit crown, actually a PFM crown. As I roll the impression over, we can see that we have a couple of issues. We got to pull over there on that margin. Becomes a little unclear as we come around here. Looks like there's you can see the margin around here and then a little groove there. Anytime I do that, it's usually from cutting off an old crown, but maybe not, because then it would probably be a little bit more up on the prep. And if we zoom way in, you can see that shiny bit of material there. That always scares me just a little bit, to see it look so much shinier, that lump right in the middle compared to, say, all the impression material around it. Sometimes that's an indication of something that's not fully set. It feels fully set, but I think most of us who've been taking impressions for a long time know that we look at the dull look of a polyvinyl, especially after it's been poured, for example, and then we look at this shininess and kind of maybe how soft it is too, if you look at that when I poke it with the Explorer versus maybe if I poke this. I don't know, it just seems kind of suspicious, because why does it look so shiny and nothing else does anywhere else around there? And of course, when you look at an impression like this, it can be difficult to know exactly what's going on. And I always say that one of the ways we get to cheat here at the laboratory is by having the stone model to look at, something that the dentist never gets to see. It's a view that we get once we pour up the impression. And this is also one of my most compelling reasons for taking digital impressions, because instead of ending up with an impression like this, when we take a digital impression, what we actually see on the monitor is not the impression at all, but a virtual model. So at least we get to see, it's not a three-dimensional stone model like this, but we do get to see a virtual model and not an impression. So as we look at this, it does look like there might be something going on here. That doesn't look necessarily like the way it was prepped, especially with this groove kind of coming out of here like we see there. If we look at the buccal margin, We kind of see that little area I was pointing to where I said it looks like that's where I cut off a groove, but the margin does become kind of indistinct there as we get to the mid-buccal portion. But the bigger thing is, it looks to me like we have a big undercut. And as I look over on the lingual at this undercut, if you look at it from, the more you tilt it, the better it looks. And you look at it there, you go, hey, nice, that's a nice margin. And then as you bring it over this way, you can tell that the whole prep is in fact leaning to the lingual. And so it's difficult as we roll over to try to visualize that margin in the base of that wall. We never see the buccal at the same time. So the notes indicate the doctor was called and he said, do your best. And that always cracks me up when a doctor says, do your best. It's like, okay, now we're going to draw the line in the sand and we're all going to hold ourselves to, the highest level of quality possible. But I understand, for all I know, this was a patient who was gagging and there was other issues that made it extremely difficult to work on this patient. So judge not lest ye be judged. I just know that probably it's going to be difficult to make a great crown. We're going to have to make a lot of relief on the inside of that crown for it to go down with that kind of undercut. And so what happened was that the dentist called and said that crown didn't fit. I'm going to take a new impression. And this is the new impression that I saw sitting in the box. And as I looked at it, it had already been poured, but it kind of struck me as odd as I looked at it because I saw color on the inside of that besides just the purple. So it does look like the same impression materials that he used before. But before, notice how the wash material is throughout, the purple materials throughout the entire impression. And here on the new one, it's just really kind of concentrated in that one area. And so when I saw this color, I thought it was a residue from the stone, and then I started poking, and there was something hard in there. And that's when I actually looked and read the rest of the RX. And there's a note from the doctor saying that the crown needs to be remade because it didn't fit, the margins wouldn't close. And it said that the crown was inside of here. And I thought, oh, that's interesting. And this is actually being pried out for the first time, as you can see, as I snap a Bard Parker, using it for the wrong purpose. If I had a cord packer here, I'd probably use it. Really, all I'm trying to do is get this crown out. It's already been poured, so I guess at this point I can go in and just kind of jam around. And let's take a look at that crown. Well, he certainly adjusted the internal portion of it to try to get it to fit, even though it didn't quite fit. And for some reason, he used the crown kind of as a copper band technique. I never used copper bands in dental school when I was there from until 1988. We never actually used them. But it looks like he relined the crown. In fact, it says that he did on the RX with the impression material, resat it on the prep, and then took a pickup impression over that. And that was the fascinating part of it to me, is why you would do that versus just taking a new impression. To squirt the impression material in here and push that down on the tooth, I guess you would think that, well, there's no way that I can miss this impression with that kind of adaptation. So with that crown buried in there when it came in, the model and die people poured it up, and there's this chunk out of the lingual, and you look at it and you go, wow, well, that should have been prepped to get rid of the undercut, but at this point there's a weird chunk over there on the lingual, and as I look at the impression, you can see where that chunk is right there, and it actually is on the tooth itself, and now it's represented here. And it makes me wonder what the doctor was thinking when he took the crown and put the impression material inside, sat it down onto the tooth, and then took an impression. Now, his notes that came back did say that the crown didn't fit, but the bite was good and the shade was good. So I guess he was thinking with the fact that the bite was good, you could put this into place and have maybe the patient bite down on it. I'm not exactly sure how it went down. I don't know if that sat first and then the overall impression was taken, but I couldn't really come up with a good reason why you would want the crown holding the light body material on the prep. And it doesn't necessarily look like it worked unless that's what the actual prep looks like, but that's kind of hard to believe that's what the prep looks like, because I don't even know how you would do that. It's smooth. I don't see any burr marks. It's kind of wedge shaped. It doesn't even look necessarily like a football burr, so I'm not exactly sure. We're going to have to wait to see if that crown fits when we hear back from the dentist again. What I find to be interesting is to see whether or not the crown that he sent back actually fits the old model that we sent out, because he said it definitely didn't fit the patient's tooth. You know, all we can do at the lab, and I'm not trying to absolve us of responsibility, but really, as you know, all we can do at the lab is make sure that the crown fits the model before it leaves. You know, it comes down to the impression whether or not what fits the model will fit the patient's mouth. But I really don't know how this is going to fit on here. And it kind of fits. It kind of fits. I would expect it to be a little bit loose. A little bit of play. Remember that big undercut on the lingual? I said we're going to have to leave some room for that. And yeah, it's loose, but it kind of fits, and it seems like it goes down. Enough so where if it fit like this, I'm 99.9% sure if it fit, of course there's no retention, but if it fit like that in the patient's mouth, that this crown would have been cemented. So I think it stands to reason that there was in fact something wrong with the first impression, because it looks like it fit the model well enough to have the doctor cement it, although he didn't cement it because it didn't fit the tooth, and therefore that caused him to take the second impression, which had the crown as the copper band, if you will, holding the light body material, and then a pickup with blue mousse around it. And I'd love to hear from anybody if that's a technique they've used or found to be effective, but it seems weird to use this as the quote-unquote impression tray for the light body material, especially when it didn't fit. And you can tell how much it didn't fit, because if you look, you know, when I still had the crown in here before I busted off the barred Parker and everything, you could kind of see some color change, but it's not like you could see spots of the crown showing through. So it looks like, you know, they left a ton of relief to get rid of that, to accommodate that undercut on the prep. And as a result, there's a pretty thick layer of impression material on the inside of that. But I'm not sure why that was being used as an impression carrier on top of the tooth, and why a new impression just wasn't taken. So if you know, or if you've used this technique, please write in and let me know, because I would like to be educated about that and hear why that might be a good technique. And at this point, all we can do is wait to hear back from the doctor and see if the the new crown that we make on this model fits. I'd be surprised if he wants us to make it, but you'd be surprised sometimes what dentists ask for. So we might in fact just make the crown on here if he doesn't want to take another impression, and tells us to do our best and send it out, and we'll see what happens on attempt number 2.
Thank you for that, Dr. D.
My pleasure.
Now let's go to a segment we call Viewer Mail. This week's viewer mail comes to us from Dr. Adam Gutwine, and he writes, Dear Dr. DeTola, I'm only a year out of dental school, and I heard your podcast on the Thriving Dentist Show. I definitely have average hands, and I now use your reverse prep technique for all my preps. They look fantastic. And he's got 2 long questions, so I'm going to break it up. And the first one says, I've yet to prep a CEREC crown, but it looks like these crowns have broad, flat shoulder margins. Are they compatible with the nice chamfer margin created with your reverse prep technique? And do you have any suggestions for simplifying my CEREC preps?
Well, Adam, I'm in love with you already, just because you admitted that you have average hands. And I'd never really heard a speaker do that before I did it, even though I've known for a while that I had average hands, about 13 years now. So it's cool to hear you say that, and it's great to hear you say that reverse prep technique is helping you get some great results. That's kind of what it's all about, is trying to get above average results, you know, for those of us with average hands. In regards to your question about CEREC crowns, you know, in the old days, pre-EMAX, pre-2007, all the different materials that could be milled into a CEREC crown were all ceramic materials that were not strong enough to be cemented into place. They had to be bonded, and they all required that shoulder margin that you're talking about with that rounded internal line angle. But they needed that big shoulder in order to be effective. Since 2007, it's gotten a lot easier to do CEREC crowns, because now all of a sudden we've got EMAX, a high-strength, all-ceramic cementable crown that'll tolerate a chamfer margin very well. Can't do a feather edge with it, but it loves the chamfer margin. And when you use that round burr in the reverse prep technique, I always refer to that as either a deep chamfer or a shallow shoulder, kind of just depending on how much you refine it after you've actually done that round burr depth cut around the gingival margin. So I would say no, there's no need to do shoulders anymore. Most of the guys that I know who are using CEREC and doing crowns on a regular basis are using EMAX and are using them with chamfer margins.
All right, and his second question says, this practice utilizes Traxident, but I've been using your double cord technique and I'm getting awesome results. With Traxident, I didn't really like that I couldn't see my margins as well as when double zero cord is in place. I know Traxident is really expensive and I'm very fortunate that the office is encouraging me to use it. Is there a learning curve that I need to get over, or in your experience, is double cord the way to go? Thank you.
Well, Adam, that's another good question. And let's not pick on Traxident. I know that's the one you use, but let's just refer to kind of all these non-cord paste retraction systems. Most of them have something like aluminum chloride in it to stop bleeding, and they do that very well. So sometimes if I'm doing like a direct composite and I'm taking out an old amalgam and I've got irritation and bleeding, you could put Traxident or Expasil or something else down, pack it down into that area, rinse it out 8 to 10 minutes later, and you wouldn't have any bleeding in there. You can use it if you're going to cement a crown and the gingiva is irritated. It'll stop bleeding for that. But the one thing I find that these products don't do is exactly what you mentioned. They do not retract tissue very well, and it doesn't make sense that they would. When you look at two retraction cords, like a double zero and a 2 that I like to use if I have the room and the attached gingiva to do it, when you put those two solid structures into the sulcus, that bottom cord, the double zero, is going to retract the tissue vertically, or apically, I should say, about 0.5 millimeter. And then that second cord, the number 2 cord, the top cord, is actually going to retract that tissue laterally. So if you just use a one-cord technique like I was taught in dental school, really all you do is retract the gingiva apically. You really don't get that moat that we're looking for, that huge space where it makes it almost impossible not to get a good impression, and that's what that top cord does. Now, when you put a clay-like material in there, it's got to be soft enough to be able to come out of the syringe. There was one company that came out with a product where it actually expanded, and so you would put it in the sulcus and supposedly it would expand, but the difficulties getting it in the sulcus, and we all know this just from packing cord. Packing cord's not that easy in the beginning, and then you become accomplished at it, and it just becomes tedious. But yes, in my mind, it still absolutely provides the best results. Now, if you're doing something like a no-prep veneer and you're not going subgingival, then I'm fine with Traxident or Expasil or any of these non-cord retraction paste systems. But if I'm replacing a previous crown that had a subgingival margin, or I'm doing a crown where I'm going to have a slight subgingival margin, I've got to move the tissue back and open up that sulcus laterally. And the best way I know to do that is with the 2-cord technique, even though it's kind of a pain sometimes. I'm lucky here in California, my assistant can pack cord. So I'll often put the first cord in because it's step 2 of that reverse prep technique, and then she'll put all the top ones in and the comper caps over it, and then I'll come back in 8 to 10 minutes and take the impression. So 2 great questions, Adam, and I hope we get the chance to meet one day. I'd love to give you an average handshake so we can touch our average hands together and see if we can make some average magic.
Wow.
That's awesome. What does Adam win for writing in 1 year out of dental school, and he's already paying attention to what he's doing?
See?
Took me 12 to start paying attention to what I was doing.
Some are slow learners here.
Exactly.
How about this photograph?
Oh, that's with the
Perfect Smile.
Perfect Smile in place.
Yes.
That's Perfect Smile version 1. Version 2 I actually like better, and the version 2 are still being made right now, but you'll like version 2 even better.
Right. I think this is pretty funny because just the look on my face is just like, really, dude, come on.
And you know what?
And we're going to sign it because, of course.
He name-dropped the reverse preparation kit. So I'm going to send one out to him too because I know he used it. So Adam, this is going to come out to you along with this signed picture with your name on it, and thanks so much for writing in. We really appreciate that. Megan, have you any news?
Yes, I have. A Metro Transit patrol dog is getting the expensive dental surgery that he needs, thanks to the generous support of strangers. The 3-year-old pup needs 3 root canals and 4 crowns. He damaged his teeth by biting down on metal grates in the police car where he's held. When Metro officials refused to pay for the treatment, the dog's handler told the story on a local news station and set up a website for donations. Within 10 minutes of the story airing, they far exceeded the amount needed to cover the cost of the procedure. The dog's handler says the extra money will be put into a fund to help other patrol dogs.
That's, in a sense, a heartwarming story, but I can't believe the police department wouldn't pay for it. I thought they worshipped, these animals and loved them. I can't believe it was up to the handler to do it.
I know, and I guess the official response from the patrol, the police says they were saying that they were phasing out the dogs from the service, and so if a dog reached a point where physically he couldn't do the task or was getting older or whatever, that they would just let him retire. Okay, that's one thing. I understand that, I get it, but then just to leave the dog in pain, in misery with all the dental problems, wrong.
Did it say why they're getting rid of the dogs? Are they going to attack crows, or are they switching to another animal?
I don't know. I think they were just, for whatever reason, they were phasing it out because it's for the transit, so it's not just everyday PD. It's for the Metro Transit. So apparently they were taking dogs out of that. I'm not sure over how long a period of time that they're phasing them out, but they said that was the reason.
That's weird. I guess maybe it's just because it's transit, but with the bomb-sniffing dogs and the drug-sniffing dogs, you would think that they would be part of those kind of law enforcement efforts for a long time. And I didn't really understand. He was chewing the bars in the back of the...
I believe so, yes. And I think maybe just if the dog was, in the back for whatever reason, they're parked or whatever, and he was... My dog Parker, who I mentioned probably way too much on this show, I think he would chew on it too. It's just boredom, and they chew on it. And so
I feel like toss a piece of rawhide back there.
Right.
Let him save his teeth and enjoy what he's chewing at the same time.
I don't think rawhide's good for dogs, though, but I could be wrong.
I think it's better than metal bars, though. I think it's the lesser of two evils.
We can agree on that.
Anything else?
Yes. We've told many stories here on Chairside Live about dentists practicing without a license, out of their home or garage. But now, do we have to worry about the materials used by legitimate dentists? Apparently, many states don't require dental labs or their employees to be trained, certified, licensed, or even registered with a state health department. A man in Ohio was recently found running a disgustingly dirty, albeit legal, dental lab in his basement. Just how common is this? Well, a 2008 survey showed a significantly low number of dentists know if their lab meets regulation criteria with the state or federal government.
That's true. Many states don't actually have requirements for dental laboratories. They have to have a business license.
Sure.
But that's about it. They don't have to be certified. They don't have to register with the dental board. And the reality is that the dentist could make the restorations in his own office if he wanted to. And so he could have his kids make the restorations if he wanted to, or a monkey, or a trained dog, or anybody make it.
Parker?
Parker could do it. He has to inspect the crown, check it for fit and everything before it goes in the mouth. And he should know what materials it's made of. So I think it rests on the dentist's shoulder. So it really almost, in a sense, doesn't matter if you have a super modern looking laboratory like we do here, or if it's just at somebody's house. You said you had some pictures of it.
I do.
Sounds like it might be the media kind of overblowing this situation, but no, that's...
Are you kidding me?
That is a little gross. And granted, those could all, like that denture right there, could still fit very well. And as disgusting as this looks, I guarantee you whatever mouth that's going into is dirtier than what you see here.
Gosh,
that's
gross.
just the reality of working in the human mouth.
And maybe I just have the benefit of comparison, but walking through our lab, it is pristine. And so then to look at pictures like this, it's night and day, and that is terrifying.
It's a little mind-boggling, and you would never want to send a patient over there to have the lab take the shade, for a crown or something like that. But honestly, just looking at what's here, it looks like it's a removable lab, like they're just doing dentures and things like that. And so I guess it's not as surprising.
I don't care what they're doing. Look at that. That looks like an abandoned garage.
But the prices are so good.
Oh gosh. It's just, and then what's more expensive is the medical treatment you have to do to get rid of the diseases that it gave you.
Well, again, this just looks dusty to me.
Nope.
This doesn't look as horrible as it would be in a patient's mouth. You could have a lab that operated out of the back of a truck, like a UPS truck. I'd probably be cleaner than that, but so it really almost doesn't matter. It is up to the dentist, and that's really why the one piece of communication that needs to be there is the lab letting the dentist know what materials were used, and that but they really don't even have to be
I'm sorry, it's a little bit terrifying.
Certified in any way.
I don't think there's anything you could say to me that's going to make me feel better about that story.
No, we're not. I'm not encouraging dentists to use this
Right,
lab.
I know.
You can go ahead and send your stuff here to Gladwell.
Please do.
Where it's a lot cleaner. Nothing filthy like that. Well, that about wraps it up for this edition of Chairside Live. On behalf of myself, Megan, the CSL crew, and everybody here at the lab, I want to thank you for your time and your continued commitment to quality dentistry.
We'll see you next time. Many states don't require dental labs or their employees to be trained, certified, licensed, or even registered with a state health department.
Sorry, Jimmy. I didn't have these pictures open.
And I was going to laugh my head off. What did you do midway through that story? Did you spit up or something?
No, I went to swallow and yes, water squirt out.
Oh. My Indian grandpa was so weird. He used to make red-eye gravy, which is bacon grease and black coffee. My dog Parker, who I mentioned probably way too much on this show,